you've used the phrase allocating resources, and so we all understand the idea of scarcity. We've heard of what happened in places like Italy and when there were a limited number of resources to go around. And so I remember whenever I was little, there was a situation where in some educational circles, they were doing these ethic tests or these just weird situational ethic things. If you're on a lifeboat and you have only enough resources, basically, who should you kill? And I think it's important for us to say, okay, we're not. When you talk about allocating resources in an emergency situation, there's been an explosion and you can only care for so many people at a time. There are some criteria that are used to determine allocation of resources, but the criteria isn't the value of one human life over another, right? I mean, help us think through that biblically as Christians and as medical ethicists.
Yeah, I think that's so important. And I try to ground myself in the truth that our lives are a gift, and I think it's in God that we live and move and have our being, and so there's no other ground for our being than God. And so at the bottom of it, life is a gift, and so that has a lot of implications. One of those implications or set of implications that we don't have the right to place value on other people's lives because we didn't give them those lives, and we don't have authority over those lives. And so, yeah, I think that that always has to kind of walk us back from deciding, does this person have the quality of life, so to speak, that would warrant us providing these resources, or is this person valuable enough to society, or is this is the way this person living eliminate them from these resources. And I think because life is a gift, we have to be really careful not to make decisions based on that. It's better, especially in a public health crisis, to try to base our decisions on who we think will benefit from an intervention in a medical sense. And we can never be objective in these decisions, but as much as we can to use the tools we have in medicine to say, okay, this this person or these people are most likely to benefit from this resource, and because of that, we want to make sure that we value life by getting this resource to those people that are going to benefit from it. The hard thing is that means that some people aren't going to benefit as much from that resource, and that's really hard. There's no way around that.
Jeff, given what Aaron has just said and what Diana said, as we've talked about the value of life, why would someone ever say have a DNR or do not resuscitate order as a Christian? Why would that sometimes be an appropriate order to give?
Yeah. I mean, it's a very individual thing for different people. And so if you're a 25-year-old person, might be very different than if you're a 90-year-old with terminal cancer. But basically, the way I explain this to my patients is if we were successful in our resuscitation, which under the very best circumstances happens about 25% of the time in a hospital setting, and way less than that if it happens in the community, but you're going to be restored to the state that you were before. And so if you have a 90-year-old who's on dying of cancer, and you're going to restore them in a code, you're going to restore them to a 90-year-old dying of cancer. It's not like you're going to, do anything more drastic than that. And so I think it's really important for people to be realistic of expectations. There's just a sense of desperation that people want to do everything they can at the end of life without a sense of peace. I'm not talking about, a fatalistic approach to things, but there is a sense of peace in which when I die, provided I'm not a 25-year-old who's been in a car accident and has a family to care for, it's all nuanced by situation. So I want to be careful with that. But when I die, I'm ready. And you know what? If I'm there, and especially if it's at the end of a long chronic illness, I don't want you bringing me back to suffer for another 3 or 4 years. And so I think that's just an important thing to think about. If you move that into the oh, sorry, go ahead.
Well, one ER doctor explained it to me as it's the difference between prolonging death or prolonging life. So sometimes a DNR just prolongs the death.
Yeah.
You bring them back to die again over and over again, in a sense.
Yeah, there is a sense in which in America, we're not very good at this. We spend 25% of all of our healthcare expenditure on the last 24 hours of life. And that just shows, I mean, that is an enormous amount of money, right? And some of that is because we want to do the very best for people. But there also is a sense in which we have patients we know may have 3 or 4 months to live, and they're telling us, do everything that you can for me. And to me, that's a really sad situation, to see where there's just clinging to this life with that kind of fear and anxiety. When you take that code situation, I said, if you bring it back to the COVID situation, we know that if you are a patient who has coronavirus and you end up in an ICU on a ventilator, your outcomes are really poor anyway. It's a disease that's really slow, and people don't get out of the ICU or off of ventilators. It's 10 days, 12 days, and the overall outcomes are really poor. And so when a patient arrests who has coronavirus, and many people come in the room, that whole process that Aaron was describing of pushing on the chest and breathing for them really has a tremendous potential to cause droplets to spread in the room, and is a really high-risk situation for the healthcare providers who respond to that. And so that's when you've heard some of this controversy. So, remember we talked about return of spontaneous circulation being about 25 to 30% in a normal setting. For a COVID patient, it's about 5 or 10%. If they arrest, that's about the chances that you're going to get them back, with tremendous risk to everybody else in the room. And so like what we do for that, our responders, when they show up, they are supposed to take them extra time to fully protect themselves, to put on their personal protective equipment. We're really limiting the number of people who go into the room to resuscitate that patient. Only the very most experienced person is going to try to put a tube in their throat to breathe for them if we can. All that is just to decrease risk, because we know that the chances of a successful outcome are less than a normal situation, and the risk to all the people in the room are much higher. So that's where some of this controversy about resuscitation has come from, especially related to COVID patients. But I think all of us here would disagree with there's been some talk, and I still think it's theoretical talk, but across the board blanket statement that we are not going to resuscitate any person. I so far have not heard, and maybe I'm wrong, but I've not heard of an institution that's made a blanket policy like that. And we would certainly oppose doing that. I think Aaron is on our ethics committee. Aaron, is that safe to say?
Yeah, certainly. And I don't know whether there would come a point where we'd think differently, but yeah, I agree with you. And it doesn't mean that we wouldn't necessarily talk to a patient or encourage a patient that probably us resuscitating you is a bad idea. I think we bear responsibility to tell patients that sometimes, but yeah, I agree across the board. It doesn't seem fitting, at least right now. Yeah.